and welcome to another Pipe Pearl. Today's Pearl, we're going to tackle abdominal pain consultation. Now, for those that have been playing in the clinical game a while, they'll definitely understand the complexity that is about to follow with abdominal pain. It's a rather common presentation and it is incredibly diverse of what the problem could be. Obviously, the abdominal region spans right from underneath the diaphragm all the way down into the pelvic region. And in males, it can also include refer pain from the testicles. So it's a large differential diagnosis. So today the focus is going to be on consultation, mostly looking at subjective data and simple examination techniques you can do in order to filter down the dangerous from the mundane, things you can deal with, things you can't, and obviously highlight some red flags. So just to highlight the complexity further, when someone comes in with a complaint of abdominal pain, you always need to consider whether or not it is an emergency. There are a lot of surgical cases and a lot of medical problems like pancreatitis, cholecystitis that sit in that acute emergency space. And then it can also be indigestion, bloating, constipation, diarrhea, the list keeps going on and on. So always consider that emergency space first. Always look at your patient, see if they need any urgent care, and then move on from there. As I've alluded to, surgical pain can come from a number of different areas. Obviously, your GIT, your genitourinary area, cardiovascular referred pain, can be musculoskeletal, can need to be referred to surgical, and can even include psychosomatic or psychiatric type pain. Whilst we'd never jump to that one first, there is plenty of cases that really lead to that psychiatric line. The bottom line indicates other consultation lessons that I have done or will do in the future that overlap with this abdominal pain one. So diarrhea constipation is a common one, and there's very special investigations to do for both of those. Urinary disorders is an obvious link thanks to the kidneys and the bladder being in the region, and then you also have abnormal uterine bleeds for females and of course testicular pain for males. In the distant future, I'll also probably look at doing individual lessons on each pathophysiological state. So I won't go into too much detail of each disorder today in the consultation, otherwise the lesson will go on a very long time, but I'll do individual disorder-based lessons in the future that will help complement your overall knowledge. So let's look at the etiology and the epidemiology. As you could imagine, it is very, very difficult to get exact numbers. So the studies vary all over the place. There's a lot of overlap and there's a lot of inconsistencies with the findings, obviously based on a bias of what the study's trying to prove, the demographic they're looking at, the age of the people that they're looking at as well. Adults and children have very different pathophysiological states when it's got to do with abdominal pain. So the studies are all over the place. Okay, so what I've done is I've got a bunch of probably the largest studies that looked at a demographic of adults, excluded pregnant women, that sort of thing, and then got the numbers that will best help our demographic. So common causes for that group that I've just specified, 33% of all the patients coming in were non-specific abdominal pain. They couldn't find an answer. They did the tests, they did the examinations, and they couldn't find an answer. Now, whether or not they decided to waste time, money, resources of going deep enough to find the answer, probably not. And it usually indicates that the abdominal pain was self-limiting and controllable by symptomatic means. The reason it's good to bring up is you're going to be doing consultations on people with abdominal pain, and you're not going to know why they have abdominal pain. That's just inevitable, especially in the primary healthcare space. They'll need to be referred on. Most primary healthcare patients will in fact be referred on. Of the acute abdominal pain cases that could be quantified, appendicitis came out a lot, which is good because it's one that we definitely have to look out for. It was 20% related to bowel, which included your irritable bowel, if it's such a thing, and also your colic disorders, constipation, and diarrhea. So basically any disorder associated with the bowel. And then there was 10% of the cases that were referred from other regions that we'll delve into. Of the cases, 12% of them were emergent cases, so it led to something that needed to be treated quite aggressively. Now, based on all the studies' recommendation is the bad ones and the patient can get the best care really depends on how detailed and complete of an examination the clinician is willing to do. So from here, we're going to look a little bit deeper into the pain and why it's so complex, and then look at the consultation of abdominal pain to help really support that detailed and complete examination to support our patients. So looking at the pathophysiology of the pain, not the disorders themselves, it sort of leads to a better understanding of why certain classic presentations like appendicitis, cholecystitis, pancreatitis, even diverticulitis are a large part of the result of the pain they feel is due to the dual innervation of the abdomen of both visceral and somatic nerves. So your visceral nerves are part of the autonomic nervous system, and they innervate with the viscera, so the actual organs themselves. As you can see, the vagus nerve innervating with the actual viscera and the organs. These nerves are sensitive to mechanical distension. So that's like your baroreceptors. When it feels pressure, feels that with gas, they're going to feel that pain. They're also sensitive to inflammation, ischemia, smooth muscle contraction, and things like colic that you'll see, that rhythmic contraction of pain. The pain is often midline, poorly localized, deep, and dull. So it's often what's known as a parasympathetic pain. If you remember some of my other lessons, it doesn't invoke a dangerous or violent response from the patient as opposed to sympathetic or somatic pain. So the pain from the foregut structures, such as your stomach, liver, pancreas, gallbladder, they tend to radiate to the epigastrium. You'll find similar symptoms in areas of the midgut and the hindgut as well. So there's just small bowel, appendix, large bowel, and pretty much everything in the lower abdomen also has this poorly localized, deep, dull pain. When you look at somatic sensory nerves, they provide sensation to the peritoneal area. Somatic pain is sharper and better localized. When you're dealing with somatic pain, it suggests a peritoneal irritation. Classic example of this is McBurney's point. So when the appendix is inflamed or ruptures, it irritates the peritoneal area, causing this somatic pain. If there's a problem with the appendix prior to profound inflammation and rupturing, you'll feel the visceral pain. So because viscera and somatic afferent nerve fibers share the spinal cord segment, it's very common for you to get visceral pain that's felt as somatic disturbances. And that's explained in the one I just mentioned, which is your appendicitis, but it's also example in cholecystitis, where you get that radiating pain to the right scapula. Later in the lesson, we'll look at other areas of radiating pain, and the reason that radiating pain occurs is because the organ starts with the pain, the visceral pain, but then it has connecting somatic nerves, which runs along that particular somatotome, causing the pain in that region. Let's get stuck into the examination itself. So it starts with subjective data, and this is where most of the bang for the buck goal of your subjective investigation is to remember your anatomy and physiology, what is normal, and then try to ask questions, get information that could indicate what is abnormal about the patient's presentation and why that could possibly be occurring. So remember, at all stages, we need to consider an emergency. So look at the patient's appearance, and then right throughout the subjective investigation and objective findings, always consider escalating it to an emergency. When we do an event, we want to know the onset. We want to know whether it's acute, subacute, chronic. Okay, I know that generally can take part in the pain profile, but onset is important. So we want to know, when did this start? What were they doing when it started as well? Associated symptoms are a big thing when you're dealing with abdominal pain. Vomiting, diarrhea, constipation, very common accompanying symptoms. And in the case of vomiting, diarrhea, and constipation, it has a very specific line of questioning that follows, which will be covered in the other lessons. If someone has a fever, it is a perfect indication that obviously we need to double check it with the objective data, but an indication that someone has a pathology. Okay, they have some sort of pathology, and that pathology is bad enough to communicate with the blood in order to get a fever. Fatigue is generally indicative to either exhaustion from pain, malabsorption because of a disorder, or inability to sleep as well. So quite debilitating for the patient. So get the picture, find out what they're dealing with. It can also be your general carousal symptoms, your common cold, urinary problems. It doesn't matter what they say. Take that associated symptom and don't dismiss it. Abdominal pain is a symptom, not a disorder. We need to link all the things together in order to find out what's going on. Past history is vital in this case. We need to know if the patient has had similar events exactly like they're describing now. It's very common for patients to come in over and over and over again, especially if they've been poorly diagnosed with irritable bowel syndrome. In case you're wondering, it's a diagnosis of exclusion. So it generally means that people haven't excluded everything. So they're going to keep coming in with the problem. So try to get a pattern, see if you can help them out. We want to know their medical history, what sort of medical problems they have, diabetes, all that sort of stuff, which includes their family medical history, especially if it's associated with Crohn's disease. Surgical history is very important, particularly if they've had any abdominal surgery in the past. If they've already had an appendectomy, they can still feel pain down there, but at least you know it's not going to rupture. So it's sort of a bonus. Social history we can go through: alcohol intake, smoking intake, traveling, all that sort of stuff ties into social history, what they've been doing, who they've been playing with, what countries have they visited. Helps build a profile of potential pathogens that they could have picked up that we may not be used to. Dietary is an interesting one. If you want to continuous reading information that contradicts themselves, then start reading dietary information. It is very difficult, but there are certain dietary patterns, particularly if someone has recently changed their dietary patterns, it can cause irritation to the abdominal area, therefore causing the pain. So try not to jump on your own bias with diet, and mostly look for if someone has changed their diet recently, just to help build a picture of the person's history. From there, we move into our subjective questioning, and we start with the pain profile. The presentation is pain, so we start with a pain profile. Palliation and provocation is interesting. If things make it worse, like movement, you're generally dealing with a musculoskeletal or a mass disorder, contracting over a mass causing the pain. If it's caused by food intake, then it can be things like a peptic ulcer. If it happens straight away, it's gastric. If it happens 1 or 2 hours after, you're generally looking at a duodenal ulcer. If it's associated with fatty food, it can link to cholecystitis. And if things make it feel better, like increasing pressure on it, like curling up in a ball, that sort of thing, then you're generally dealing with some sort of colicky-like pain, and you want to get more information about that particular pain. The quality tells you a lot. As we just discussed in pathophysiology, if it's a dull, deep sort of pain, you're generally dealing with a visceral problem and a nerve in particular. Most of the time, it's got to do with stretching of the small intestine. The large intestine has the ability to stretch. Pretty scary, large-wise. It can get huge without any necessary discomfort. But as soon as the small bowel starts to get inflamed, then that can cause significant amount of pain. So generally when bacteria, the wrong bacteria, gets into the small bowel, causes gas, and that's where you get your colicky type pain. Sharp pain is your somatic pain. So it's either referred pain from a significant inflammation or problem, and it generally refers along those somatozones, but it can also be musculoskeletal related as well. The region, when you're dealing with a primary healthcare complaint and you have time, always work on the 9 regions of the abdomen as opposed to the 4 quadrants. It is far more specific, and it does tend to have correlations with the organs that sit under it. A lot of these things are caused by visceral pain first, so if it is isolated to a particular region and they can describe it, then most of the time, not always, but most of the time, it is associated with the underlying organ itself. So always use the 9 regions as opposed to the 4 quadrants when you're dealing with primary healthcare. Another part of the R is obviously radiation. You want to know where this pain is referred to. So as you can see, liver and gallbladder, classic one, like your lungs and diaphragm, it's linked very, very closely. Irritation of the liver and gallbladder can obviously be in the region, the right hypochondriac region, but it also can refer to the neck. Okay, we all know the heart. An interesting one to look at is the kidneys. That's the one that basically makes a pair of shorts for the patient. Okay, so it's actually a very large referred pain. People that have a kidney problem can spread right down into their groin. Someone has ureter problems, it is often felt along the lining of the groin, pretty much where your abductor muscles are. Urinary, pretty much on the bladder, straight through to the back. A classic sign for pancreatic pain is they feel it in the front and then it shoots straight through to the back. So it's very isolated to that area. It just goes straight through to the back, same as the stomach. So pancreatic pain is often confused for stomach pain, and you need associated symptoms like food, reflux, that sort of thing, in order to narrow down which one you're actually talking about. But radiation of pain is a big thing, and you need to get a full picture when you're dealing with your pain profile. Severity is important, and characteristics of the severity based on palliation and provocation is more helpful. So what is it like at rest? What does it peak to? And then you can link that to timing where you're dealing with your colicky like pain. So there's really only one type of colic pain that is your true colic. The other two that often get thrown out there are not really colic. So colicky pain itself is, it's another way of saying gas or pressure-based pain. It's rhythmic pain with regular spasms reoccurring, building to a climax and then fading. It's virtually very, very difficult to find the very true underlying cause, but the common cause is some sort of intestinal obstruction or intestinal stretching. When you hear things like biliary or kidney colic, that's mostly referring to stones as opposed to this colicky rhythmic pattern. And whilst it does have rhythmic like pain, your biliary pain will often peak, wave a little bit, and then drop. You're generally associated with food. Your kidney pain follows a similar pattern to intestinal colic, where it rises and falls, but the peaks are higher and the lows are generally lower, whereas intestinal colic is constant rhythmic motion of peaks and troughs for generally a longer duration of time as well. So that's where the term severity and time can give us an indication of what we're dealing with. So that's generally the pain profile that you need to go through when you're dealing with abdominal pain. From there, based on the symptoms that the patient gives us, we have special subjective questioning associated with diarrhea, constipation, difficulty urinating, abnormal uterine bleed. All of these will be covered in another lesson. But you can also have specific questions about anorexia. Now, anorexia meaning the loss of appetite. I don't want to eat. You can find out why they don't want to eat, find out if it is pain related or if the sensation of hunger is no longer there. Nausea and vomiting, we want to know what sort of nausea they have. Is it associated with increased salivary production, or is it just a feeling sick in the stomach? Is there vomiting? How violent is it? How controlled is it? What does it look like when it comes out? how much have you vomited, those sort of questions as well. So that's your subjective questioning part of the investigation. From there, we obviously move into allergies and medications, which also play a massive role in abdominal pain. So allergies, we need to distinguish between allergies and sensitivities. A lot of the time, especially with modern marketing, people will mention that they're allergic to certain foods. In fact, that allergic is in fact a sensitivity. So almost half the population has a sensitivity to foods. It's very common to be sensitive to foods. It's very common to be intermittently sensitive to food. If you're in a state where your body is already inflamed, so you already have these inflammatory mediators floating around your body, you actually can be more susceptible to gastrointestinal irritation from food than you would be if you didn't have these preloading inflammatory conditions. So it's very common for foods to cause some sort of discomfort, and that's where the irritable bowel umbrella has been thrown out, because whatever it is irritating your bowel. So find out what foods they're sensitive to, find out what foods they could be sensitive to. It's linked to a change in diet. If someone's had a history of giardia, they can in fact become lactose intolerant because of that giardia without even realizing, continuing to eat lactose and therefore getting the irritable bowel symptoms. So foods may not be allergies, may in fact be sensitivities themselves. When we move to medications, there's a myriad of things that can cause some sort of gastrointestinal upset, which has your referred pain. Alcohol, and I mean a good amount of alcohol, is associated with cholecystitis. Antibiotics like erythromycin can be quite rough on the gut, so that can cause your pain. Corticosteroid is common for causing inflammatory type pain, but it's mostly due to the destruction of the lining as opposed to inflammatory, obviously. Iron supplements irritate the stomach, and your non-steroidal anti-inflammatories, in particular your COX-2 inhibitors, ibuprofen for example, are infamous for causing peptic ulcers. So someone who's been on a large dose and constant dose of NSAIDs can have peptic ulcers and increased acid production, that sort of thing. Nicotine obviously has a link to cancers, esophageal, gastric cancers, but people who are trying to quit and have taken a large amount of nicotine gum, or any gum for that matter, can have associated diarrhea and abdominal pain as a result. Caffeine, whilst I never like to bag caffeine because it's a lifeblood, if you have large amounts of caffeine, you can get stomach spasms, irritations, which can cause pain. People that aren't used to it and have just taken a large amount of caffeine due to stress, not sleeping well, whatever it is, can have the associated pain from the medication. From there, you can also dive deep, and I mean really deep, into the world of natural therapies to see what they're on, see what they're taking, see if it's new, and could it potentially cause some sort of irritation to the stomach. If you don't know, that's fine. There's a lot of medications out there, but just get a list of what the person has been taking that can help build the profile. And that completes the very large and detailed subjective investigation. From there, we obviously move into the objective investigation, and there's a few things that must happen every time, and then a couple of bonus extras for certain demographics. So things you must do, obviously, is consider after the subjective investigation, is it an emergency? Should you have picked it up earlier? Are you wasting this person's time when they should be being treated? Always consider this throughout the examination. I know I sound like a broken record, but it's important. You need to get a set of vital signs. Hypotension, heart problems, they can all lead to abdominal pain. So get the full set of vital signs: respiratory rate, SpO2, pulse, blood pressure. Have a look at their perfusion status and their oxygen status. See if it could be a contributing factor. Temperature, we've already talked about. They're all very important. They must be taken, must be recorded. Believe it or not, doing an oral exam can be enlightening when you're dealing with abdominal pain. So you can get these things, inflammatory lesions around the mouth, which can indicate a vitamin deficiency or malabsorption. That's where you link into your spiroe disorders, small bowel disorders that can be causing these pains. The oral cavity itself should be examined in detail because you're looking for ulcers. It can be linked to celiac or even Crohn's disease. A pale, smooth, shiny tongue indicates an iron deficiency sometimes, or a big, beefy red tongue can be seen in folate or vitamin B12 deficiency. So having a good look at that tongue can also tell you good things. Obviously, vitamin B12 linking to alcoholism, stronger links to pancreatitis. Okay, all builds a picture. Smelling the person's breath, as gross as it sounds, can also be enlightening. If you don't quite know what it links to, that's fine. Just describe the breath. There's a condition or a finding that you have, which is fectohepaticus. Yep, sounds like a Harry Potter spell, but that's a distinctive smell that, I don't know how to describe it, but basically it's indicative to a liver disorder, and it's quite a rotten type smell. And obviously you have your fruity acetone breath that leads to your ketoremia, so an increase in ketones found in your blood. Someone's coming in over the age of 40, which is not unheard of, and they're complaining of abdominal pain, and it's not an obvious abdominal pain, like, oh yeah, this is classic this. An ECG can be a good idea because an MI, particularly in people over 40, can present as abdominal pain. So just do an ECG, rule it out, rule it in. Either way, the patient gets a better treatment. The bulk of the abdominal examination for objective finding comes from inspection, auscultation, percussion, and palpation in that order. Okay, if you percuss and palpate before you auscultate, you'll get false positives because it increases peristalsis and bowel sounds, so it's not helpful. So you need to do it in that order. We're not going to go into too much detail in this because that itself is going to be a lesson alone that's going to look at the abdominal examination in detail. Otherwise, this lesson is going to be twice as long. So they're very important to do. Future lesson to come on those points. So have a look out for it, or make sure you have a watch of that video after you watch this one to get a complete picture. Doing a urinalysis can be very helpful. Not even when you're dealing with just urinary problems for referred pain, but dealing with the health of the actual gastrointestinal system and accessory organs can also bring light. You've got your ketones that you can find. You have your bilirubin that you will find, which is indicative of gallbladder problems. So a urinalysis, very simple to do, very easy test, and can be very, very helpful. If you want more details on urinalysis, then you can check my detailed lesson on urinalysis that explains all the findings that you have. From there, you can continue your investigation with pathology. So full blood count, inflammatory mediators, liver function test, very, very common test to do. Vitamin B12 can also be thrown in there. And obviously in women, pregnancy test can be and should be considered when it needs to be considered. So most of the time, some places will just do a pregnancy test on every female that comes in. If the female that comes in says she's a lesbian and has never had male to female intercourse, she knows the risks of ectopic pregnancy. They're pretty scary, so you can probably trust her. Just give her education. She's adamant. Probably don't go through the tests because it's a little bit rude, really, when you think about it. So you can do pathology, and you can also do radiology. Okay, plain films are still used, especially for things like constipation, but then you can also go down the realms of ultrasounds to find the problem. Bottom line is, remember, most of these are going to be referred, especially the difficult ones or the complex one, the big pain profiles. They're going to be referred. They're going to go on to further investigations. Do physically what you can to paint a full picture, and then just know, working in different departments, that investigation will include imagery and pathology. From there, we have all our data. Hooray, all the data. Now we have to filter it. We have to go through the data and try to make the best decision. We do not have to find the answer. Remember the stats. And those stats are from people that have gone through complete workups and still didn't find a problem. 1/3 didn't find the cause. So don't spend hours deliberating, looking through the books, trying to find the answer, walking around with a walking stick, writing on a whiteboard. Don't go down that line. Okay, it's not fun for anybody, but we do need to filter the information. And again, we need to consider, is the patient stable? Is the patient unstable? If the patient's unstable, then ask yourself, why the hell aren't you treating this person as an emergency? Okay, because they should be. So that's the first thing to look through. From there, review the subjective data. You'll obviously have a line of thought, where you're going, review it. What does the pain file tell us? What does the symptoms tell us? What region can we narrow this down to? Does the objective finding support it? Do we need to go on further? What is the patient's profile, their radiology, telling us it's most likely to be? And the bottom line is how much does this pain actually affect the patient? Because if it's not that bad, then they've got time to go on to further investigations, book an appointment, deeper consultation, whatever it is. If it is debilitating, then focus on those debilitating symptoms first and then have follow-ups to try to find out what is going on. Bottom line is no one expects everyone to diagnose what the abdominal pain is on first presentation. What is expected is complete examinations and good patient care. That's it. So speaking of patient care, we obviously start with education. We talk about how the patient can help themselves. Okay, what are some self-managing tips, tricks in order to support this pain, especially if it's colicky-like pain? Regular exercise, stable diet. Not going to recommend a good diet. Okay, try not to fall down to that trap, but recommending foods that are obviously irritating can be an idea for the person to look into removing them from the diet. If someone has ulcers, then having high acidic foods or chilies is not a good idea. That's a nice easy one. So be careful with diet because it's complex, filled with bias, and quite difficult to actually offer sound advice these days based on any evidence. So give them education on non-medication based treatments that they can do. Like I mentioned, exercise, movements. Yoga can even help with abdominal pain, believe it or not. I know it sounds quite hippie-like, but it can. When we move into the realms of treatment, into medication, we need to find out what they need. This could be a whole range of things. Analgesia can be needed, but be very careful with your NSAIDs. I know paracetamol technically is an NSAID, but it's one of the good ones. It doesn't actually cause gastro irritation, so it can be a good point of call. A lot of the time, pain relief will actually come from other medications as opposed to your direct pain relief. In fact, even with your kidney stones, you'll find an anti-inflammatory is better than an opioid for pain relief, just as a side note. So consider the realms of what's causing the pain and see if you can help with that. Hyoscine brutobromide is a good choice. Buscopan, great choice for colicky type pain, that spasmodic rhythmic pain that you get. It can be enough just to relieve it. Antiemetics are a good choice if they're vomiting, they have nausea. Diarrhea and constipation medicine is a large topic and will obviously be covered in both of those lessons because not all antidiarrheal and stool softeners are created equal, and sometimes the choice really needs to be decided with a bit more detail than's provided in this particular lesson. Antibiotics, not commonly done on presentation of abdominal pain unless that abdominal pain is associated with sepsis, appendicitis, things like that, a good obvious infection. And then we can obviously have our classic PPIs if it's peptic ulcer related. The person can be on those PPIs for months, 3 to 6 months on average before the treatment will actually be completed. Restrictions, many variables. Bottom line is look after the patient. Look after the patient's comfort. Give the patient time to recover. Don't put the patient in environments that is going to be overtly uncomfortable, but also don't completely rule them out of work or doing anything just because of abdominal pain. Okay, this abdominal pain can continue for a long period of time, and it can actually be something that the patient unfortunately just has to learn to live with as well for some of the disorders. So weigh up what you think it is, how debilitating the pain is, what the patient does, and give restrictions to suit. Passing on infections isn't really the risk associated with abdominal pain, very low risk for that one. So if the patient can work, they should. Keeping active, getting back to the workspace is always a good idea. Referral, evacuation, most of these are going to be referred. Remember, you're not going to get the answer day one. They may just need to be referred for further testing. Maybe it needs to be referred for a different line of consultation with a medical officer. They may need to be evacuated from the field. Okay, that's your choice, and it's usually banked on how much pain the person is and how much it affects what they're currently doing, and if they need emergent further investigation as well. So that brings us to the end of the Pearl on abdominal pain. As you can see, there's a lot more for you to delve into. Some of those things that you can delve into will be provided as part of this overall series. It's a much deeper topic, as you are aware. So continue your study, continue building a full picture of what abdominal pain could be and how to best treat our patients. Bottom line, don't always assume it's the mundane. Don't always assume it's dietary related. Never throw out the diagnosis irritable bowel syndrome, because it's not really a thing unless you have excluded everything else, and you're not going to exclude everything else in your first consultation. So be aware of that. Do the patient a favor, do your practice a favor, and your reputation a favor. Do a complete and detailed examination, particularly focusing on good subjective questioning. But until next time, take care.